Okay, so we're continuing and finishing up the neurology lecture. The next subject that we will discuss is dementia. And, dementia basically the loss of memory. And there are different types of causes for dementia. It depends on the type, and it depends on the severity. That's how much memory loss you can get. So there's a video here that you can watch in general, but I'm not going to play it. I'm going to go on and just talk about it a little bit, but we will talk about Alzheimer's, which is very, very important to know. So dementia, when we talk about dementia, it's loss of memory, and it's a group of conditions, okay, that actually plays a major role in the cortical function decrease. So you have decreased in the majority of the cortex, whatever the area of the cortex, and especially the areas where it has to do with memory. So cognitive and motor coordination also. In general, when you have dementia, we're talking about short-term memory, okay? But it can last for, it can go into the long-term memory also. But in general, we're discussing short-term memory that, these people, would not remember where they put the slippers on, where did they put the slippers, place them under the bed or whatever. But they can tell you stuff like what happened in, like 30 years ago or 35 years ago. So it's more concentrated of a short-term memory rather than a long-term memory. You will have behavioral and personality changes within these individuals. And it has different causes, but in general, there is vascular diseases, atherosclerosis, infections, toxins, genetic conditions that can lead to that. So it's not always one thing. So when we say dementia, it could be the underlying disease could be different. The most common ones are Alzheimer's, for example. Alzheimer's is very common, and that's the one that we see all the time. We'll talk about it in details a little bit. And there's another one that's called Creutzfeldt-Jakob disease, or we call it sometimes subacute spongy encephalitis. Okay, this is the one that you eat contaminated food and you have dementia, and then you can die from this. So within 6 to 8 months or so, people can die from this. Now this is kind of related to mad cow, if you ever heard about it, which is one type of encephalitis that cows get. But it's similar to it. And patients will be, they get this type of dementia from eating contaminated food that is from sick animals. Okay, and then AIDS patients get dementia also, and that has something to do with HIV. So that's a different one here. Now let's talk about Alzheimer's, because that's the one that you see all the time, and people getting Alzheimer's. Again, there's a degeneration of the brain in general, and this is a healthy brain, and this is an Alzheimer brain. So you can see the difference between them. So you have atrophy of the brain tissue, as you get it. Now we don't know the cause for this. Sometimes they say genetic. Sometimes they, so we'll talk about different risk factors in general. Let's watch a short video, and then we'll come back and talk about this.
In healthy people, all sensations, movements, thoughts, memories, and feelings are the result of signals that pass through billions of nerve cells or neurons in the brain. Neurons constantly communicate with each other through electrical charges that travel down axons, causing the release of chemicals across tiny gaps to neighboring neurons. Other cells in the brain, such as astrocytes and microglia, clear away debris and help keep neurons healthy. In a person with Alzheimer's disease, the most basic form of dementia, toxic changes in the brain destroy this healthy balance. These changes may occur years, even decades, before the first signs of dementia. Researchers believe that this process involves two proteins called beta amyloid and tau, which somehow become toxic to the brain. It appears that abnormal tau accumulates, eventually forming tangles inside neurons. And beta amyloid clumps into plaques, which slowly build up between neurons. As the level of amyloid reaches a tipping point, there is a rapid spread of tau throughout the brain. But tau and beta amyloid may not be the only factors involved in Alzheimer's. Other changes that affect the brain may also play a role over time. The vascular system may fail to deliver sufficient blood and nutrients to the brain. The brain may lack the glucose needed to power its activity. Chronic inflammation sets in as microglial cells fail to clear away debris, and astrocytes react to distressed microglia. Eventually, neurons lose their ability to communicate. As neurons die, the brain shrinks, beginning in the hippocampus, a part of the brain important to learning and memory. People may begin to experience memory loss, impaired decision-making, and language problems. As more neurons die throughout the brain, a person with Alzheimer's gradually loses the ability to think, remember, make decisions, and function independently.
Right. That's a nice brief one. So the major thing that you need to remember about this, that it has something to do with a couple proteins that can actually cause you to have Alzheimer's. So we have with the amyloid plaques that you will see, and that's beta amyloid. It's called beta amyloid, and that's the protein. And then there's a neurofibrillary tangles, that you have inside the brain. That's called the tau protein. These are the main things that are significant of Alzheimer's. So when we need to detect if you have Alzheimer's or not, we look for these proteins here. And if we find them, then most likely the diagnosis is Alzheimer's. So it's not part of aging. Some people, they say when you age, you get Alzheimer's automatically. It's not part. You have to have a risk factor for it. Family history, they put you in a higher risk of getting it. Hypertension, hypercholesterolemia. Again, all these have something to do with the blood supply going to the brain that becomes decreased. When this happens, then your brain you can get Alzheimer's because of that. So the mortality rate increases, the prevalence increases when you have Alzheimer's, to death. Complications, all these could cause a little complications when you talk about Alzheimer's. We talk about infections, urinary tract or pneumonia in older people, injuries related to falls, malnutrition, dehydration, and decubitus ulcers, which has to do with diabetes. So again, these are just complications that you can get because of, complications that you can get if you get Alzheimer's. So manifestation is insidious. That means it just happens suddenly. The course can go up between 10 and 20 years, having Alzheimer's. It's a very complicated type of disease to handle and control. So you're going to get plenty of patients with Alzheimer's that you need to monitor and keep an eye on all the time. Memory loss, problem with abstract, so cognitive stuff, a lot of cognitive deterioration and disorientation, loss of judgment, all these things, personality changes. I can never forget the time when I was a medical student. I was driving down on 55 and I-55, and I see a woman on the side of the road with her, nightgown, and she's just walking there. And I was just, a student like you, and I said, that's not normal, So I pulled over, and my God, she was disoriented. She did not know what she was. Her house was up, close to the highway, but she found a way to come and walk down all the way across. And I'm glad she was just walking on the side. So I called the cops, and they found her family, and they were just about maybe a mile away. She walked about a mile, So that's really something. I could never forget this incident here. All right, so these people could be very disoriented. They don't know what's going on. They can walk around and don't know where they're going. They get hallucinations sometimes, incontinence because they can't control their bowel or their bladder. All right, so how do you diagnose people like that? Again, you have to do the blood test. You have to find those proteins, the beta amyloids and the tau. And if you find them, then you do a CAT scan. You can you can do an MRI to see the mass of the brain, and usually it starts shrinking, with Alzheimer's. Different areas, especially in the inside part of the brain, close to the ventricles. So you'll see like the ventricles getting enlarged, and when the ventricles get more enlarged than normal, then you have loss of brain tissue. These are some of the drugs that can help out, with Alzheimer's, but it doesn't mean that you come out of it, but it can help out with memory and all that. The donepezil, which is Aricept. It's very, very commonly used. It's a cholinesterase inhibitor, which is, it increases the amount of acetylcholine. And then you have vitamin E that helps. Kingo, this is a natural thing. And this is also an alkaloid, which is a natural type of herb that you can buy over the counter, or it could be prescribed, So other strategies to help people with Alzheimer's could be memory aids, calendars, practice their brain, always practice their cognitive ability. You'll be sitting with them and doing different type of exercises all day long for them, type of memory exercises, social support, coping strategies, and all that has to be there. Continuous supervision, by the way, that's one thing for sure. You can't just let them be on their own. You got to have somebody with them all the time. All right, let's talk about cerebral palsy. So cerebral palsy is another brain disorder that has something to do with deficiency in oxygen. So you have less oxygen reaching the brain tissue and the spinal cord. And when this happens, then the neurons are not going to have enough oxygen to survive. And then eventually you're going to get a bunch of different signs and symptoms with that. Usually interruption of oxygen supply to the fetus, to the cerebellum, and we know the cerebellum has something to do with coordination and balance. So you lose the coordination and balance in this case, and then it hits the cortex, different parts of the cortex that can lead to different types of abnormalities, within the cells. So, during the many of these kids, they get it in the prenatal period. So you have less oxygen reaching the brain within the prenatal area, and it could be due to many different factors. And then you're born with that. Now, it doesn't have to be prenatal only. It could happen after the baby's born also. But usually you have permanently affected motor activity. So permanently you affect the motor movement and muscle coordination. Cognitive communication skills and functions. It's more common in male, African Americans, and lower socioeconomic status for some reason. So these are some risk factors that you can get with cerebral palsy. Premature babies, low birth weight, bridge birth. You know what a bridge birth is? Position in the
Yeah,
pregnancy?
it's when the fetus comes out feet first.
Yeah, usually, they lay down like a C shape like this, and then eventually the legs comes before the head. So that's, so multiple fetuses also another risk factor. Maternal or fetal hypoglycemia. Uh, Infections during pregnancy can lead to that also. So all these can lead to reduced amount of oxygen reaching the brain of the fetus, and specifically mercury. So that's why if you're pregnant, you want to stay away from, any type of poisonous type of metals like mercury and so on. So that's why they stopped all kind of mercury equipments like blood pressures, sphygmomanometers, and all that. They used to make them with mercury, column type. All right, cerebral hemorrhage can lead to that, during the fetus stage, infections, neurological infections, and head injuries. So all these are risk factors for cerebral palsy. Now, you probably noticed a few boys walking around or on a wheelchair, and they have cerebral palsy. They're very spastic. Okay, they have hyperreflexia. Okay, so their reflexes are very hyperactive. They have different types of walk. If you notice, these are different types of cerebral palsy. So they could be just, like paralyzed, like one side of their body. It could be just the lower part also, and the upper, but it could be the whole body. And this is the way they walk or sit on a chair, depending if they can walk or not. With this, you give them the hemiplegic. You can give them a walker, and they can use the good leg to help them walk. This one you need a wheelchair. So this is wheelchair also. So it depends on the type. They can go on a wheelchair or not. So usually the positions of the limbs are very awkward. You can see them either sitting like this or sitting like this or sitting like that on a wheelchair. So depending on the type that they have of palsy, that's how they position themselves on the chair. They have excessive drooling, difficulty swallowing, so that's why you have to feed them. And impaired sucking, they can't suck, so you have to use a feeding tube on them mainly. Speech issues, facial grimaces. Development delays, so they develop very late. Difficulty in precise motion. So complications, usually they don't live long, but if they do, they really, have issues, and you have to be with them all the time. So it depends on the type of cerebral palsy they have, so they do have balance coordination, contractures, okay, different types of contractions, different part of the body, malnutrition because of the feeding issues, communication, speech, very difficult to learn to talk to them talking back to you. Their cognition is very, very low. They get seizures, some of them do, visual issues, urinary incontinence, and chronic pain. So it's a very serious situation for these kids to get cerebral palsy. Diagnosis, history, physical exam, you look at the history, if anything happened during prenatal, infection, trauma, any kind of issue. By the way, during delivery, we used to use forceps to pull the head out, and they don't use it anymore now because this forceps used to actually squeeze on the baby's head, and a bunch of kids came out with cerebral palsy because of the trauma that actually the physician caused, in pulling the head out, trying to pull with using the forceps. So they stopped using that. Head magnetic resonance imaging, so MRI, electroencephalography, you can do that, hearing, vision. So all that could diagnose it. So treatment, again, it's very difficult to treat these kids because of the deficiency of oxygen, but you can give them muscle relaxant if they're spastic. You can give them botulinum toxins just to, this if they have any type of so you cause spasm with this, okay? You paralyze the muscle if you get a lot of an involuntary type of contracture or contraction. So that's where this sits. Anti-seizure medications if they get seizures, pain medications, occupational therapy, braces, orthopedic type of devices, ambulation devices. All these things could help actually someone that has cerebral palsy. Let's talk about meningitis, which is very, very significant. And meningitis is inflammation of the meninges. And meninges, we said the meninges are 3 layers that covers the brain and the spinal cord. Looking at the dura outside, then arachnoid, then pia inside, touching the brain. So all that, now you inflame the dura in general. And the dura is that has a lot of nerve endings, and that's where the pain is caused from. So when you inflame the meninges, then you get a significant type of headache, neck tension because of that. So it is very significant. So inflammation of the meninges, CSF may also become affected. So because of in the subarachnoid space, we have CSF, and then it could be infected also. So you're going to see bacteria, in there if it's bacterial. So 2 types of meningitis, either it's bacterial or it's viral. So, viruses, these are different viruses that can actually causes meningitis. Enterovirus, measles, influenza, herpes. Here we put tumors in there. It's not certain tumor-like viruses, tumor-caused viruses like HPV and stuff like that. Allergen can lead to that, different types of viruses that leads to allergies. If it's bacterial, then you have these type of bacteria. These are the most common type of bacteria: Neisseria meningitidis, Streptococcus pneumonia, and Haemophilus influenza. These are the most common. Haemophilus influenza is very, very common in children. So this is a case where, someone, it happens a lot with athletes, you guys, because they share showers. And if somebody, get meningitis, because it could be, touching, or, also if, playing close, contact type of sports like basketball, and, sweats and, saliva and all that. And, this could be one of the contamination that you can get. It's contagious, so you can get these viruses and bacteria, one from the other. So you have an inflammation. When you have inflammation, you have swelling, you have increased intracranial pressure within the vault of the cranium. So usually it's more in younger adults, because they're very close with each other, kind of, during gatherings and all that. So it's more risky if you have one has meningitis, the other person can have it. So, athletes, pregnancy, pregnant woman, can, they can get a lot of things. If you're pregnant, you're at higher risk automatically for many things, including this. Working with animals, so it's more of encephalitis, probably, working with animals, than meningitis. But still, you can get meningitis, working with sick animals. Okay, cows, any type, goats, goat. It depends on, the type of animal there. Immune deficient people is at higher risk. So here's what you can get, if you have meningitis. These are a couple of signs that we look at when you diagnose someone with meningitis. They can get what we call epistathnis. You know, epistathnis is this type of curvature. Okay, so the baby will have this type of contour here when we diagnose with meningitis. So they will have this type of curvature. Also, we can do, they have meningismus, okay, which is a severe headache, stiff neck, fever, chills, mental status changes, nausea, vomiting, photophobia, and agitation. These are significant signs and symptoms of meningitis. Now, we have to do a blood test and get some culture and also a CSF. So you need to do an epidural type of test where you can get some CSF from them to check if they have the bacterial or viral infections. So bulging fontanelle on the babies. So if you remember, you have a fontanelle here, anterior and posterior fontanelle. So if you have meningitis, eventually the brain, the meninges is going to inflame and it's going to push down to the openings, and you're gonna have bulging fontanelle. Decreased consciousness, poor feeding, irritability on the baby, they're crying all the time, tachypnea, and rash. So this is like one test that we will do, Brudzinski's sign. Let's talk about them here. So Brudzinski's sign is when you take, if you suspect meningitis, you take somebody's leg and you bring it up this way and you push back with it. When you push back, you know, or you lift it up and you push back a little bit, then the patient will feel neck pain. So you'll feel, you know, so the patient will feel neck pain when you do this. So that's called the Kering sign. So also you can do a Brudzinski sign on them, and that is basically you let them bend their knee like this, and then you pull up their head here, and they have you know, it causes a lot of pain. So these types of pain that you get when we do these signs on them, then you can think of meningitis possibly, most likely. You can do a throat culture to check for bacterial infection, maybe prior to meningitis. Lumbar puncture, CSF again, to check for viruses and all that. With lumbar puncture, you know, when you have viruses, usually you have increase in lymphocytes, and bacteria, you have increase in proteins there. So that's one thing that you see when you have a blood test, when you do a blood test on, a CSF, cerebrospinal fluid test. So you get it through, you know, you do a lumbar puncture on. CT and head scan can also possibly show inflammation and infection. So if it's bacterial, you give them antibiotics, hydration, fever management, vaccination, depends on the bacteria that you have there. If it's viral, it's self-limiting. There's not much you can do. You can give antiviral medications also to it, but you have to go through it. And usually, sometimes it takes, you know, between 4 weeks to 3 months to recover from that. So it's a long management type of treatment there. So these are some of the complications that you can get because of that: seizures, neurological hearing loss, blindness, all that you can get from meningitis. So encephalitis is inflammation of the brain tissue. Meningitis is inflammation of the meninges. So encephalitis, we're talking about the brain tissue inside. So there are different types of encephalitis depending on what you get. It could be bacterial, it could be viral also. So viruses, these are the different viruses can lead to encephalitis, which is inflammation of the brain. Echovirus, Coxsackie virus. Okay, so Coxsackie virus, poliovirus, adenovirus, all these cytomegalovirus, eastern equine virus, You covered a bunch of these in microbiology, I believe, and these are all causing encephalitis. Bacteria, these are some of the bacterial, syphilis, TB, Lyme disease, Legionella is the type of bacteria that can lead to that. So, so all these are, now what happened, you have inflammation of the brain. So these are different symptoms of an inflammation. So you have vasodilation, increased capillary permeability, leukocyte infiltration, all that is happening in the brain because of the inflammation, okay? So the brain, and sometimes, it follows the spinal cord follows also. So you don't just get infect the brain, you can infect the spinal cord along with it. So these are some risk factors that you can get. Usually immunocompromised, young children, infants, older adults, everybody can get an encephalitis. Again, those living in high incidence area, people that, we find this a lot in the third world countries than here, but we can get it here also because they're exposed to all these viruses there and bacteria. Flu-like symptoms, that's what it starts with, and then you start having neck rigidity, confusion, hallucination, personality change, very similar to meningitis. Okay, but here we can have bulging fentanyl. This is what you can get that with meningitis, you can get that with encephalitis also. So here's the bulging fentanyl right there. You can see it. Now, how do you diagnose this? You're going to see bacteria on the MRI here. So all this is inflamed tissue, okay? So this is an inflamed tissue here in the brain that can, you look at it and you think of encephalitis. History and physical, you'll know that these people have been exposed to different types of bacteria or viruses before that. And with the neck rigidity and the headaches and all that they get. But the MRI kind of diagnosed this by doing that, then you can see it. You can see the very inflamed area in this area. So you think of them probably encephalitis rather than meningitis. Lumbar puncture, you can do that to check for bacteria or viruses. Polymerase chain reaction, you can do like a different DNA type of testing on them. Serum viral antibodies to see if they have the antibodies of the viruses inside the body, inside the CSF, or inside the blood. So how do you treat encephalitis? Depending on the type of infection you have, rest, adequate nutrition, viral self-limiting again, respiratory support, medication, analgesics, antipyretic, antiviral if it's viral. Bacterial, you give them some antibiotic therapy, you give them some corticosteroids for the inflammation to reduce the edema, anti-seizure medication, sedatives for, to calm them down. Prevention, vaccinations, if they live in an area which has, which makes them exposed to any of these viruses or bacteria, get them vaccinated, wear protective clothing, and then using mosquito repellent type of nets and all that. So complications, cerebral edema, cerebral hemorrhage, and brain damage could be part of the complications from encephalitis. All right, that takes us into brain tumors. Okay, so brain tumors, we have different types of brain tumors. So we know that we have all the tissue in there. It could be the meninges, and we know that the nerve cells that the brains are made out of are either neurons or glial cells, if you remember. So what are the glial cells? Who wants to name some of the glial cells that we have in our brain? I say neuroglial cells. What are we dealing with here? What kind of cells? Name a couple for me.
Astrocytes?
Astrocytes is one, yes. What else?
Oligodendrocytes.
Yep, oligodendrocytes. What else? microglial cells, right? Ependymal cells. And all these are different types of glial cells. They are connective tissue type of cells that you have in the brain that connects neurons together, that connects that can connect blood vessels along with it and all that. So, so brain tumors in general depend. You have two types: either they're primary or secondary. Primary, they come from the nerve cells themselves. Okay. And secondary, it means it's somewhere else and it spreads to the brain. So that's basically what we're dealing with here. So, breast cancer, colon cancer, kidney cancer, lung cancer, melanoma, and sarcoma, all these can cause brain tumors. So it can go up. And if you have a brain tumor, eventually you're going to eventually have increase in intracranial pressure. The pressure inside is going to increase because the mass increases within the cranial vault, and that would, so how do we, what do we deal with? How did we deal with brain tumors? If it's primary tumor, usually it's genetic. So we run. If somebody in your family get brain tumors, there's a good chance that somebody will get a brain tumor, in your family. Risk factors, advanced age, the older you get, the higher risk of you getting brain tumors, specifically your primary, because you slow down. Nerve cells slows down as you get older, and metabolism slows down. So mitosis can decrease, and if it becomes hyperactive in a neoplastic way, you're at higher risk of causing some brain tumor when you are older. Exposure to radiation and occupational chemicals also has something to do with this. So prevalence and mortality rates high among Caucasians and males. For some reason, men gets it more than women, and specifically Caucasian. Neurological deficits would be some of the complications: seizures, personality changes. Headaches would be one of the major symptoms that you get. So here are some of the symptoms depending on the type and where it is. Okay, so let's look at the first one that is referred to as acoustic neuroma. So neuroma is a nerve cell itself, neuron. So these neurons that sits in cranial nerve number 8, which is the acoustic nerve going to your ear, you can get a neuroma in here in your ear. Okay, and that is just a nerve cell type of type of tumor. Now, this is not considered a brain tumor, but it is more likely the nerve itself becoming like neoplastic. This one kind of these patients will get, so here's your acoustic neuroma close coming out of the cranial nerve number 8, connecting to the medulla oblongata, or actually to the part of the medulla, and then the pons in this case here. That's where the nerve comes from, so you get a neuroma out of that nerve here. So people will not be hearing because of this. Okay, so you'll have the patient being deaf. Ringing in the ear, hearing loss, tinnitus or tinnitus, treatment, observation, or surgery. Sometimes you have to go in and you can do that through the mouth actually, and go in there and do it. Prognosis, hearing loss can persist after treatment. So this is referred to as acoustic neuroma. Okay, vestibular schwannoma also, because it comes out of the Schwann cells. And the Schwann cells, if you remember, who knows what the Schwann cells do?
Aren't they the cells that help produce myelin for the peripheral nerves?
Yes, they produce myelin sheaths. absolutely. They produce myelin sheets in the peripheral nerves. Okay, so Schwann cells, you find them in the peripheral nerves, including the cranial nerves also. So you find them in there. All right, the next one is chondroma. Now the chondroma, I'm talking here before I get to the brain, so here are nerves again. So a chondroma, this is one type that comes from the base of the skull, okay? And it can range between the base of the skull all the way down the spinal cord, okay? So it can come down the spinal cord all the way from up there, up in the brain. It can lead all the way down to the tail of the spinal cord. So chondromas, it grows slowly, gradually, extending into the bone and then in the soft tissues also. So it depends on the location. It could be in the base of the skull again, all the way down into the spinal cord. Surgery, radiation, depending on the stage of this tumor. Some of them will get radiation only. Some of them you can do surgery on them, depending on the area and how much risky it is to do surgery on them. 68%, 5 years, 40%, 10 years. All right, craniopharyngioma. Craniopharyngioma, it's in the cranium, and you have a pharyngioma, and that's usually the pituitary gland, right over here. So we know it comes out of the pituitary gland at the base of the brain, and they usually happens in children between 5 and 14 years old. Very common, more common in children than adults. Again, it can lead to hyperactive type of pituitary, which increases the different types of hormones that leads to overweight, excessive thirst, increased urination. So all the pituitary, whatever, and also it is very close to the eye because the optic nerve, right over here. So it can really lead to visual issues also. It can decrease the amount of growth hormone, so it can slow you down from growing if you're a child. And either it gives you early or delayed puberty, depending on the size of the tumor and what part of the pituitary does it affect. So again, you can do resection on it, radiation therapy, 90% survival rate, which is good. So it's done. They can do it through the nose, the nasal cavity. They get in here and then they get there and then they take the tumor out. Most of these tumors are like, even though they grow within a certain cells, but they're benign. That means they stay within an area. They're capsulated, so you can take the whole tumor out, Glioma is one that comes out of different types of neuroglial cells. So these are the glial cells: astrocytoma, ependymoma, oligodendroglioma. So these are the different gliomas, okay? These gliomas are malignant, so they can actually spread into the rest of the body. They're primary brain tumors, but they're malignant, so they can spread actually. So when you say blastoma, they can spread to the rest of the body. So astrocytoma, it comes out of the astrocytes. Ependinomas comes out of the ependymal cells. These are the ones that produces CSF, basically help the protection of the layer, the membrane of the ventricles. You find them by the ventricles. There are different types, either anaplastic or mixed papillary, mixopapillary ependymoma, or subependymoma. It depends on the type. The oligodendrogliomas, anaplastic, and so anaplastic, it means it is not yet spread. That's how. But eventually they spread. Eventually they go to other places. So here's your astrocytoma, grade 1, 2, and 3. It develops from astrocytes, and we know the astrocytes connect the blood vessels to the neurons, within. So it depends on the location, and you can get seizures, you can get nausea, headaches, always, you get headaches with these things, and that's how you diagnose people. People coming with severe headaches, visual, like blurred vision, double visions, vomiting. Listen, vomiting is not a good sign, so people having severe headache, persistent severe headache that's not going away, they're nauseated and they vomit and they have double vision, okay? Loss in appetite, loss of weight, most likely it's a brain tumor. It could be something else, but think of that right away, probably. But you need to do an MRI and CAT scan to rule out any type of, So biopsies will make you tell if it's an astrocytoma or something else, okay? So you're gonna do a biopsy on it. Change in mood, personality, that's one thing. You're gonna notice that these people are changing in their mood. Personality changes, difficult to think or learn, speech difficulty sometimes. Again, it depends on the area where those tumors are. Surgery is possibly if it's doable, and then radiation. 2 to 3 years prognosis. They die within 2 to 3 years usually. Ependymoma, again, this is the cell that kind of grows close to the ventricles. So if you look at a ventricle and you see some kind of lesion right there, most likely it's ependymoma, because we said these cells are the ones that kind of they line the ventricles and they produce CSF there. So you can get dizziness, balance problem, eye problem, again, double or visual headaches, vomiting, and seizures could be another other signs. So surgery, radiation, 5-year survival is 82%. So at least they live up to 5 years with this type of tumor. But usually after 5 years, they decrease in their chance of survival. They die within 10 years usually, but a lot of them, they live up to 5 years at least. Oligodendroglioma, again, it comes from oligodendrocyte, grade 1, 2, and 3, depending on the type. And this is an oligodendroglioma right there on the side. And oligodendrocytes have to do with producing myelin sheets in the brain, right? In the nerves, in the neurons of the brain. So Schwann cells produces myelin sheets in the nerve cells. Oligodendrocytes produces myelin sheets in the brain, in the CNS. So you get headaches again, seizures, weakness. So, very similar. You cannot tell until you do biopsies on them. So when you do a biopsy, you can tell which one is which. But sometimes, with this here, the ependymoma, it's very close to the ventricles, and you most likely could be ependymoma. But oligodendrogliomas, again, they have something to do with the myelin sheets, so it could be anywhere in the brain here. You need to do a biopsy in order to get that. 12-year survival, grade 3 is 3.5. So the higher the grade, the worse your prognosis. Medulloblastoma, this is the one that is the most common in children. The most common brain tumor in children is medulloblastoma. It sits on the cerebellum, which is right over here. So the cerebellum tissue, and the cerebellum has something to do with coordination and balance and all that. So that's the first thing the kid will lose. So coordination and balance movement, they become dizzy. They have eye problem vision because it's the visual center is by the occipital region of the brain right there. So it's very close to that. So they're going to end up having visual issues. Surgery, radiation therapy, chemotherapy. Now they have stem cell type of transplantation can help. Chemotherapy, 70 to 80% 5-year survival on the kids. So it's not bad. You know, they can survive up to 5 years. Most of them survive up to 5 years. Meningioma, again, it has something to do with the meninges, okay? So you have tumors of the meninges. It originates from the meninges, slow-growing benign tumor. That's very important, very slow. And headaches is the major thing because the meninges, again, specifically the dura mater, has nerve endings there. It's the one that throbs, and you have a throbbing type of headaches. Double vision also. Most of these brain tumors give you double vision because the pressure you put on the optic nerve. Hearing loss, again, it goes and it can push on the, it depends on the area, right? And your hearing center is on the temporal region. So if the temporal region, the temporal lobe get affected, hearing loss. Memory loss also on the temporal. So loss of smell, right there, you know, all of them are very close to the temporal lobe. Seizure, weakness in your arms and legs. Treatment, the same thing, radiation, chemotherapy, surgery if safe. But if it's usually, it's unsafe to take the meninges out, you know, so 61% 10-year survival. All right, we're done with the brain. Let's get to the spinal cord and do some disorders on the spinal cord. Let's watch this a little bit and then come back and discuss different disorders of the spinal cord.
The record-breaking phenomenon Parasite made history, winning 4 Academy Awards, including.
The spinal cord is the communication gateway between the brain and spinal nerves, which innervate the trunk and limbs. The cord is a long, thin tube of nervous tissue, enclosed in 3 membranes of the meninges, which in turn are protected within the bones of the vertebral column. The 31 pairs of spinal nerves arise from the cord and emerge from the vertebrae. The spinal cord extends from the brainstem to the level of upper lumbar vertebrae. In the lower lumbar and sacral regions, nerve roots descend within the spinal canal before exiting, forming the cauda equina. In cross-section, 2 types of nervous tissue can be seen in the cord: a butterfly-shaped central core of gray matter and a surrounding white matter. The gray matter contains cell bodies and dendrites of neurons. This is where neurons synapse and transmit information to each other. The white matter, on the other hand, is made of bundles of axons and serves to conduct information up and down the cord. These bundles are organized into specific groups with specific functions, forming the so-called spinal tracts. Spinal tracts are essentially high-speed cables, each carrying a certain type of information in a one-way traffic between the spinal cord and a certain area in the brain. All tracts occur on both sides, left and right, of the cord. Ascending tracts conduct sensory information up to the brain, while descending tracts convey motor instructions down the cord. Some tracts cross over to the other side of the cord before they reach the brain. They convey sensory information from one side of the body to the other side of the brain. When this happens, the information is said to be transmitted contralaterally. Tracts that stay on the same side all the way are said to conduct information ipsilaterally. Spinal nerves are mixed nerves. They contain both sensory and motor fibers. These fibers are separated shortly before they reach the spinal cord. Sensory fibers enter the cord via the dorsal root, while motor fibers exit via the ventral root. A sensory pathway typically involves 3 neurons. First-order neurons detect stimuli and transmit signals to the spinal cord. The axons of these neurons form sensory fibers that enter the cord via the dorsal root of spinal nerve. Inside the cord, first-order neurons synapse with second-order neurons, which ascend a specific tract to the brainstem. or further up to the thalamus. In some pathways, first-order neurons ascend the tract to the brainstem, where they synapse with second-order neurons, which continue to the thalamus. Third-order neurons conduct the information the rest of the way to the sensory cortex. A motor pathway usually involves two neurons. An upper motor neuron starts in the motor cortex or brainstem, and a lower motor neuron continues from the brainstem or spinal cord. They conduct motor instructions down along a specific descending tract. The axons of lower motor neurons exit the cord via the ventral root of spinal nerve, where they continue as motor fibers to effector organs. The spinal cord is also responsible for fast, involuntary responses of skeletal muscles, called somatic reflexes. Reflexes are essentially automatic and do not require input from the brain, although the brain is informed and aware, usually after the fact. A somatic reflex involves a reflex arc composed of a somatic receptor, a sensory neuron, an interneuron, a motor neuron, and an effector muscle. Some reflexes are, however, more complex and require multiple pathways, as well as central coordination from the brain. For example, when someone steps on something sharp and lifts their injured leg, the other leg also must react to keep balance or the person would fall over. This involves multiple muscles and requires contralateral pathways at several levels of the cord, as well as movement coordination from the brain.
All right, so this gave you a rough idea about the review, a little bit about the nerves in general. And what I need you to know is these peripheral nerves, when they come down, into the spinal cord eventually, from a spinal cord out or from the tissue in, as sensory and then motor coming out. They cover different areas, of your body. So it depends on the level that the spinal cord gets injured. Anything below that injury could be affected. So when you have a car accident up here and break, injure your neck, then most likely most of these nerves are going to be affected. So that's why we get paralyzed neck down. So when you get injured on different levels, it depends on the level that you get injured, with your spinal cord. Anything below that injury could be affected. So, so this is just a review from your anatomy that you've taken. Let's look at the different disorders here that can be due to, a spinal cord injury. So we're going to look at spina bifida. We're going to look at spinal cord injuries in general, like trauma and so on. We're going to look at amyotrophic lateral sclerosis. We're going to look at spinal muscular atrophy, spinal stenosis, and sphingomyelin. So let's look at spina bifida first. Let's watch a short video on spina bifida and then we'll come and discuss it. This is mainly, it has something to do with a bulging due to a missing vertebra. So think of a missing vertebra in the spine. If you're missing a vertebra, then eventually the meninges, whatever the missing vertebra, is going to bulge out. Okay, so you could have just the meninges bulging out. You could have a spinal cord bulging out also. So let's look at the different types of spina bifida, and then we'll come back and discuss this.
Spina bifida, or its most severe form, mild meningocele, is the most common central nervous system or neurologic birth defect in the world.
Mild meningocele is a defect in the spine. It's failure of the spinal cord to close?
The spinal cord, or the neural tube, as the embryologists say, forms very early in gestation, certainly before 8 weeks gestation. And spina bifida is thought to be a failure of the formation and closure of that neural tube, so that the spinal cord elements are exposed to the intrauterine environment.
It's a progressive process. It's a progressive injury, so that by the end of pregnancy, there's been direct traumatic injury to the spinal cord, and there's been injury from the amniotic fluid itself.
Because of changes in pressure and fluid flow, babies are also at risk for developing hydrocephalus,
which is a fluid buildup on the brain and which damages the developing brain.
Virtually every child with myelomeningocele or spina bifida has an Arnold Chiari malformation on X-ray. And what it is that the back part of the brain, called the cerebellum, has a lot to do with control of motor movements, is wedged down into your neck.
The cerebral spinal fluid that cushions the brain and cushions the spinal cord leaks out through the back, through the open spina bifida defect. That leads to the back part of the brain getting sucked down into the upper part of the spinal canal. That in turn can block the circulation of cerebral spinal fluid in the brain, because the fluid is produced in the brain and then there's no way for it to circulate beyond that blockage point.
So if there's a blockage in the flow of that fluid, then the water builds up inside the ventricle. So you've probably heard the term water on the brain. The water isn't on the brain, it's inside the brain. If you don't treat that, then you end up with a massively enlarged head, you die, or you end up with severe mental retardation.
So in order to minimize that ongoing damage of pressure from the fluid, the pediatric neurosurgeon places a shunt tube.
It's a simple device. This is a shunt. It's made out of silicone. This end goes through a hole in the back of the head into that water cavity and tunnels down into the skin and goes into the abdomen, which is able to absorb the fluid. It's not a cure. It treats the symptom. It doesn't treat the disease.
Once you have a shunt, there are multiple complications that can arise from it.
The shunt can become infected, which is a serious complication, because then the brain and the layers in the brain can become infected with meningitis and encephalitis. And with each bout of infection, that can affect the brain function.
And then, of course, there are mechanical problems. They clog, they break, they get to be too short, they migrate.
So it's not unusual for a child with spina bifida who has a shunt to require that shunt, and not only for life, but to have that shunt changed at least 5 or 6 times during the course of their life.
It's important for parents to understand the potential complications or ramifications of spina bifida after the diagnosis is made.
A child may experience difficulty with apnea, forgetting to breathe. They may also have breathing problems, choking, blue spells.
In the worst case, you end up with a child that's on a ventilator with a tracheostomy and a tube in the stomach to eat. And that is a huge impact on their quality of life.
Spina bifida can cause paralysis in the lower extremities that can interfere with the baby's ability to walk, or they may even be wheelchair dependent.
They also have difficulty with their bowel and bladder function.
Most of these kids, when they become older, have to catheterize, or else they have to wear diapers.
They can develop significant curvatures of the spine because of instability, bony instabilities of the spine if they have a high lesion.
Because of the lack of innervation to the feet and the ankles, there can be the formation of club feet, or the medical term is talipes, as a consequence. So that requires orthopedic intervention after birth.
And then there are problems that can come on later on in life. It's not even necessarily done when you're a baby. You can get tethered cord, which means that the nerve tissue gets caught up in scar tissue and you can lose function. So it's a lifelong issue of disability.
There we go.
All right, so so we have different types, but mainly whatever type it is has to do with the defect in the neural tube, we call it. And neural tube is the you know, during your development, all the nervous tissue comes out of that. So it is very, very common, okay? Well, it's the most common neural tube birth defect. That's what it's not very, very common. But here it depends again on the severity and the type. That's how it tells you how long you survive. You know, so again, you have spinous process of the vertebra fails to fuse, and eventually this allows the neural tube to bulge out, you know, from the so the spinal cord can come out, or only the meninges can come out. It depends on the type. So usually it happens in the lumbar region, you know, which is down in the bottom area. And these are the different types here that we have. So we can have you know, occulta. We'll talk about each one, which one is which. So occulta, just basically you have the involvement of the meninges itself. And then here you have a sac coming out, and here you have the spinal cord actually coming out. So, but we'll talk about them in details in a second here. So the main cause is unknown. It is about, you know, possibly genetic. It could be also environmental influence by environments. Family history of neural defects. So you look at people, you know, people before you, before that kid, that if anybody, any child or infant that had this defect. They relate this to folate deficiency. Sometimes certain medication can lead to that later on. You know, during pregnancy, diabetes, increased body temperature. So all these things, they're risk factors, but they're not. You have to have a defect in the spine in order to get this. You know. So let's look at occulta. And occulta, you just have a small gap, okay, in here. So you have a little bulge of the spinal nerves and the meninges coming out through this. So it's nothing serious there that you can't see. So that's why it's very, you know, so you're missing this vertebra here. That's what they're looking for. You don't have, you either have a small bulge or no bulge. So this is the least dangerous, okay, least severe type of spina bifida. Here, the spinal nerves and meninges do not usually protrude, but sometimes you have a little bit bulging, but it doesn't come out, but you have a missing vertebra. That's how you think of it. This one doesn't have much clinical manifestation, so people can live, you know, without any issue here. Just a little bit once in a while. You need to be careful with handling the baby and so on, because you have a soft spot here to the meninges. Sometimes it looks like a birthmark in here, or a tuft of hair. So you have like hair growing in this area here. So if you have hair growing in here, more hair than anything, of course the infants don't have hair, but you're going to see a bunch of hair coming out. That's called a tuft. And that's referred to as a spina bifida occulta. Okay, but if you do an X-ray, you can see that you're missing either a vertebra or at least a separation between the two vertebrae here. Meningocele, that means you have a sac coming out. So this sac bulges out, and usually you don't have the involvement of the spinal cord here. It's just a bulge, a cyst that comes out through that opening, and you have CSF sitting here. So again, because of that, you're going to end up having herniation here of the cerebellum, like in video said. So this little herniation will come down. As it comes down, it blocks the flow of the CSF. So usually the CSF comes from here and it goes around the spinal cord like this, and it comes back up. So if you have the cerebellum herniating inside, then you're going to block the flow, and you're going to have increase in CSF in the ventricles. Eventually, you're going to have a large hydrocephalus here. So you can do a transillumination, you know, like using light, fluorescent light, to see the hydrocephalus and to see the cyst in here. Again, it's full of CSF. Surgery, they can just remove this and maybe put a plate, metal plate in the back to cover the opening of the herniation here. Again, if there are not much nerves coming out, if there are nerves, you need to be careful. But if it's just a hernia of the sac, then it's operable, so they can operate on it and close it. So this is, it has a good prognosis. This is the dangerous one. This is like, it has a very low prognosis, so what you have is, again, you have this area where the vertebrae are missing, and then you have the, this is the meninges bulging out along with the spinal cord going in. So if the spinal cord is involved, that's very, very dangerous, because you're touching the spinal cord here, and it could be, the kid is paralyzed usually because you have trauma to this. So it causes the paralysis of the infant here. So meninges, spinal cord, so myelomeningocele, okay? So myelomeningocele, you have the spinal cord involved. Spinal nerves are involved, CSF protrusion. Again, you have herniation, of the brain, of the cerebellum. And you have hydrocephalus also. So the spinal canal remains open along several vertebrae in the lower or middle back. So you have opening here. Skin covers the sac. You have a skin covering the sac. And then tissue and nerves are exposed. Some nerves are exposed. And if they're exposed, then it's very painful, making the infant vulnerable to life-threatening infections. So in general, spina bifida depends on the type and severity. We do a maternal serum and amniotic fluid aspiration to test for it. And usually we find the alpha-fetoprotein level elevated in the amniotic sac. So this is one test to do in order to test for spina bifida. So alpha-fetoprotein is the significant test that tests for spina bifida. Prenatal ultrasound, spinal x-ray, spinal computed tomography, and MRI, all these could be tests that you do. Sometimes, there's nothing you can do treatment-wise. You need to do surgery on them. If it's myelomeningocele or meningocele, the occulta, usually there's nothing you can do there. Some they put a plate where you have a missing vertebra, just to make sure that it doesn't penetrate and becomes, meningocele itself from the occulta. Neurological impairment would be complications, paralysis, seizures. All these things could be caused by this spina bifida. All right, let's get into spinal cord injuries. Okay, so this is when you injure the spinal cord. So let's look at this little video here.
A spinal cord injury, or SCI, is a complete or partial damage to the spinal cord that causes permanent changes in sensation and loss of voluntary control below the site of injury. What makes an SCI so traumatic is the fact that it can happen to anyone at any time and will severely impact the person's lifestyle. It has been estimated that there are approximately 282,000 people living with SCIs in the United States, with close to 17,000 new cases of SCIs each year. The current average age of injury is 42 years, and males account for 80% of new SCI cases. The most common form of SCI, with 45% of cases, is an incomplete tetraplegia, while the least common is a complete tetraplegia. A complete SCI means that there is no sensation below the site of injury. On the other hand, an incomplete SCI refers to some retention of sensation in the affected areas of the body. According to a 2013 analysis of the National SCI Database, The leading causes of SCIs were automobile crashes and falls. Following these were gunshot wounds, motorcycle crashes, driving incidents, and medical or surgical complications. Altogether, these constitute 83.1% of SCIs since 2005. The symptoms of SCIs can vary widely. Standard symptoms include pain and numbness, inability to move extremities or walk, inability to feel pressure, heat, or cold, muscle spasms, loss of bladder and bowel control, and difficulty breathing. There are three regions to the spine: the cervical, thoracic, and lumbar. Injuries to each of these areas have different effects. If the cervical area is damaged, it can be life-threatening. Damage to the cervical area can affect the arms, legs, mid-body, and the individual's ability to breathe. The higher up the injury occurs, the worse the symptoms. Damage to the thoracic spine typically affects the legs, pelvic organs, and can impact blood pressure. Damage to the lumbar spine can affect one or both legs and may also cause incontinence. Paralysis of both the arms and legs is referred to as tetraplegia, while paralysis of just the legs is referred to as paraplegia. Unfortunately, there is currently no cure for spinal cord injury. Instead, medical professionals work at restoring what function they can and helping the individual adapt to their new way of life. On the site where the spinal cord injury is incurred, emergency personnel will immobilize the spine using a rigid neck collar and a rigid carrying board. After leaving the hospital, a patient must adapt to their new way of life, with potential limitations in motor and sensory control. For this, they may seek rehabilitation. This may include physical therapy to help strengthen muscles, assistive devices to aid with mobility and communication, occupational therapy, vocational therapy, or recreational therapy. Although there is no cure for spinal cord injuries, there are a number of technologies being developed which show promise for SCI victims.
Okay, so so spinal cord injuries, we think about motor vehicle accidents usually causing these things, falling down, falling off high, areas, so usually it's direct injury to the the spine itself and the spinal cord. So when this happens, then the nerves that comes out of that area will be affected. So anything below the injury, the level of the injury, can cause problems. So these are some of the causes in general. Sport injuries can cause this: weakness of the vertebral structure itself, okay? Rheumatoid arthritis, osteoporosis can cause these things, paralysis. If it's very, very serious, and we're talking about the spine itself, and when this happens, then the spinal cord is affected. Direct damage can occur if the spinal cord is pulled, pressed sideways, or compressed. Car accidents can cause this. This damage may occur if the head, neck, and the back twists abnormally during an accident or injury. So, hemorrhage, fluid accumulation, edema around the spinal cord can cause also these type of paralysis. But, if you have hemorrhage and you have blood covering the tissue around the spinal cord or spinal cord itself, then that's a problem, because it's going to kill the neurons that are part of the spinal cord. So when you damage the neurons within the spinal cord, then the spinal cord is not functional. Fluid accumulation around it, can lead to that. So, but fluid accumulation, if you find the cause, you can relieve that. Edema, same thing. If you can find out the cause of the edema and you lessen the edema, then it's reversible. So things are reversible and irreversible depending on the cause of that damage to the spinal cord. Um, Spinal shock, okay, this is a temporary suppression of neurological function. So again, this is temporary, it's not permanent. And you have compression of the spinal cord. Again, accidents can cause the vertebrae to push and compress against the spinal cord. And if you fix this, then you get it, you get things back. You would hope that you get it back, by the way. So you can't wait for a long time before you do surgery, because if you do not remove the compression immediately, the neurons are going to die. And if they die, they're irreversible. You don't want to kill a nerve cell. A nerve cell takes forever for it to come back. So if you damage it, there's a chance of you losing it forever. So you want to do things immediately as soon as an injury happens for you to recover. Otherwise, it's permanent. All right, so complications, you can have what we call a cauda equina syndrome. So the cauda equina are the free nerves that comes out of the tail of the spinal cord. So this is the conus medullaris, which is the tail of the spinal cord, and the cauda equina are the nerves that comes out that goes into the sacral region. So most of these goes down there, and this is the area, by the way, where we give you anesthesia and all that stuff for the spine, surgery, spinal surgery, because there's no spinal cord in this area. So we can put anesthesia in here and numb the whole area here with it. So you can do what we call saddle anesthesia. This is, when you do local anesthesia during delivery of a baby. And that's where they give you the anesthesia, down in this area, in the cauda equina area. Lower motor neuron type of symptoms. Again, if you remember, we talked about the lower motor neurons are the neurons that connects between the spinal cord and the different tissue or the muscles in the area of the body. So autonomic hyperreflexia, automatically you have hyperreflexia. So when you injure any type of neurons in general, you get hyperreflexia, massive sympathetic responses that can cause headaches, hypertension, tachycardia, seizures, all that. Usually it's above T6, all right? So a T6 would be, any injury above T6 can lead to hyperreflexia. Anything below T6 can cause hyporeflexia, by the way, because you don't have. So hyperreflexia is caused by more of an upper motor neuron than a lower motor neuron. If you remember the chart I gave you. T6 is by the thorax, and that part of the spinal cord and above it usually is related to upper motor neurons more than lower motor neurons injury. Neurogenic shock, and that's basically a vasomotor response that you get it, disruption of the sympathetic nervous impulses coming down. So these are different things that you can get as complications, because of the spinal cord injury. So it depends on the area that you injure. Again, if you injure it by the C level, cervical level of the spinal cord, it's closer to the medulla oblongata, so you're going to end up having respiratory failure. Again, immobility, it depends on the area. Down below the neck, anything below the neck, you can get everything. If you get sacral area down by the sacral region, you get constipation. Pulmonary, again, infections. These are complications that you can get because of the immobility. So you have to ask the patient to move around all the time. Urinary infection, thrombus. If without an injury, if you don't move around, you can get constipated and you get urinary tract infections. Changes in bowels and bladder function, sexual dysfunction, chronic pain, and death. So it depends on the area that you injure the spinal cord. So here's again an overview of where do you injure the spinal cord. Anything below it you get paralysis below that area there. So thoracic, lower extremities, you know, manifestation can, you know, so thoracic basically is the one by the thorax, and cervical upper. So you get all these things. If you have a cervical injury, that's the worst, because you're gonna get everything below it abnormal. The best is, well, none of them are best, but this is the least severe, which is lumbar sacral down here. You get paraplegia, which is both legs, but you're not going to get other problems up there. You're going to get problems with the legs, basically. That's it. You'll be on a wheelchair, but again. All right, diagnosis, different things that you can do. MRI, you can see a fracture here. You can see like you fractured the bones here. So that's a spinal cord injury. You could have like narrowing right there. This is a fracture here. This is a bone pushing against the spinal cord. You can see that. This one here is this. So you can see it. All right. And here again, you have a vertebra that are fractured that you can see pushing against the spinal cord here. So treatment, depending on what goes on, you want to immobilize the spine, you know, so make sure that it is not loose. You know, give cortisone for inflammation, spinal traction. The spinal traction is pulling the spine, the vertebrae away from each other to give a chance for the spinal cord to go back into its spot. So, and then you do what we call immobilization of the spine after that. Surgical repair, basically, that's what you do. Laminectomies, if you have, you know, like a herniated disc or so. Managed respiratory, and then bed rest. So long-term, again, physical, occupational, speech therapy, all these things you can do for long-term, and give them anti-spasmodic, agospasmodic agents, and you know, pain management, nutritional support, all that could be a long-term type of treatment. All right, the next one is amyotrophic lateral sclerosis. Okay, it's called Lou Gehrig disease. Okay, Lou Gehrig is a baseball player. You know, he had this, and they named this disease according to, you know, according to him. Let's watch a couple minutes video, and then we'll finish up very soon.
Amyotrophic lateral sclerosis, shortened to ALS, is a neurodegenerative disease which usually begins in adulthood and advances rapidly. It's characterized by the deterioration and loss of both upper and lower motor neurons. As the motor neurons stop sending signals, the muscles weaken, leading to paralysis. When the muscles in the diaphragm are paralyzed, this can be fatal. There is no known cure for ALS. For most people, the cause of their ALS is unknown, but some people inherit the disease from their parents. By studying the genes that are altered in these patients, scientists have pinpointed processes in the neurons that might be causing ALS. It's too early to know which of these altered processes are a result of the disease and which could be a cause, but it's clear that they affect many different aspects of the motor neuron function. Let's start in the cell body. Here, proteins that are not transported into the nucleus build up in the cytoplasm. Errors in the systems that build up and break down proteins also cause other misfolded proteins to accumulate. The different proteins can then aggregate and can become toxic to cells in several ways. For example, they can damage mitochondria, the cell's power generators. Mitochondrial damage can lead to oxidative stress, which can trigger breaks in the DNA of the cell. ALS seems to affect DNA repair processes as well. When DNA breaks are poorly repaired, it ultimately contributes to the death of the neuron. The cell's transport machinery can also be damaged. For example, ALS-affected neurons often have problems transporting RNA, proteins, and vesicles, both in the cytoplasm and along the neuron's axon. These vesicles contain important cell signaling molecules called neurotransmitters. If these can't be moved along the axon or released, the neuron can't send messages to its target cells. Damage to the cytoskeleton can also cause the axon to retract. If this happens, the axon can no longer connect to the muscle nearby and can no longer signal the muscle to contract. Other cell types can also be involved in ALS. Oligodendrocytes, which electrically insulate the axon and provide support to the motor neuron, don't work in people with ALS. Reduced uptake of neurotransmitters by astrocytes can lead to overactivation of the receptors at the synapse and death of the neuron. Finally, astrocytes and microglia can produce factors that protect or damage motor neurons. Neuronal death occurs when excessive damaging factors are produced. Further research is needed to find out which of these many processes cause the motor neuron degeneration seen in ALS patients. Targeting new drug therapies at those processes might lead to a treatment for this incurable disease.
All right, so this is a very complicated type of disorder, but it happens. And like the video showed, that it affects damage to the upper motor neuron and also the lower motor neurons. So you get symptoms of both. The mechanism, again, it's degeneration of the neurons, and it can affect different parts of the metabolism of a neuron or affect any type of movement or physiology of the neuron. So there are multiple different reasons why you get ALS, okay? But, you know, people with this, usually it can affect the nerve ability to trigger muscle movement. So motor is the major thing. So you become paralyzed eventually, and that's what happens. So paralysis, disability, that's the outcome. And many times, it depends how severe it is, eventually you die from respiratory issues. So you can't breathe anymore because your muscles, breathing muscles, will not get messages. So cognitive also issues can be affected. Cranial nerves, different cranial nerves in the brain coming out of the spinal, the medulla oblongata, the base of the skull, the brain, you know. So, all right, eventually dementia. So these are, again, possible causes. You know, glutamate, toxic, radical damage to the neuron itself eventually causes this. So antioxidant type of enzymes that they mentioned, you know, in proteases. Again, glutamate, which is an amino acid that has something to do with, you know, the messaging system of a neurotransmitter system is also affected in this case. So loss of upper motor neuron, progressive worse of the motors, you know, so you start slowly and then you get worse and worse, and then you lose all the muscles eventually. So you know, so if it's upper, then you get hyperflexia and spastic paralysis. Then later on, you have what we call flaccid paralysis, which is, you know, it's like it's stiffness. You know, this is like continuous contraction. This is more of a stiffness type of paralysis. So early manifestation, it starts with the hands, the legs, you know, and then it started going up and up further and further. So people goes on a wheelchair slowly, you know, from being clumsy, not able to walk, not able to hold any glasses, you know, cups or whatever, plates. So they become clumsy with their hands. They have a foot drop type of issue with their feet, muscle cramps, twitching. Yeah, so it could happen in the upper or lower motor neuron. So it could happen in the feet, or it could happen up by the upper extremities. Yeah, so it could happen anywhere, but slowly it progresses into, it becomes worse and worse, and eventually you need a wheelchair to be on there. Progressive paralysis. So it affects chewing, swallowing, speaking, breathing. So what else? So this is a very serious type of disorder.
Dr. J,
Yeah.
wouldn't flaccid paralysis be like floppy and loose, like flaccid, not stiff?
Yeah, it's not, well, okay. It is still paralysis, okay? And it is, yes, flaccid. This is very spastic. This is very contracted if it's upper motor. With the lower, it is paralysis, but it's looser. It is, but it's paralyzed. It's not. It's still contraction. It's contracted, but on a lower level. So it's not like like when you get a foot drop. Okay, it's flaccid. But it's spastic in a way. It's contracted, but it's looser. You have a loose foot, you see. But both of them are some type of contraction of a muscle. One is severe. This one is very severe. The spastic one. It's like a hypertonic type of contraction. This one is a looser type of contraction. But it both can cause paralysis. But you're right if you're thinking of one is looser than the other. Absolutely, yeah.
Okay.
Mm-hmm. So diagnosis HINP. So you have to look at and assess the neurological different things in there. You can there are different medications that you can help. All has something with, like this is one that can give you glutamine back a little bit. It blocks the glutamine neurotransmission. So it's an anti-spastic, so a spasmodic type of drug. So you can use that. Stem cell therapy, physical, occupational, nutritional. So yeah, I mean, no matter what, you can manage things, you can, but there's nothing much you can do to reverse this situation here. All right, the next issue, many of us can have what we call spinal stenosis. This happens during movement, if you, like you carry things, heavy things, or you get hit by a car, or, car accidents and so on, can give you stenosis. So stenosis is basically narrowing of the spinal canal, okay? And when you have narrowing of the spinal canal, then you have like the spinal cord kind of being squeezed, okay? So when you're squeezing this, you have what we call spinal stenosis, narrowing of the spinal canal where the spinal cord is sitting. Again, no cure. You got to do palliative treatment, painkillers and stuff like that. Some people, they go through surgery by loosening up, by moving the vertebra away and then just causing the spinal cord to be relieved from the pressure around it. And, it can help. Sphingomyelin. Okay, this is one type of like a cyst that sits inside the spinal cord canal, which is right over here. So you have the cyst sitting in there and can expand and elongate all the way across. So when you have a cyst here, you're going to push the spinal cord kind of from going through, and that can lead to paralysis and everything else. So and over time, this cyst is going to push on the spinal cord, and it's going to destroy it. It's going to damage the cells here. So you're not going to be having a spinal cord that is, so you're making it thinner and thinner as the cyst kind of increases. So, so feeling paralysis, weakness, stiffness, and all that. You have to remove the cyst to get to feel better surgically. So, and you remove the compression. So this cyst is causing compression against the spinal cord. That's what it's doing. And sometimes if you can't take it out, then shunting of the spinal, of the CSF has to be required because there's no circulation of the CSF going around the spinal cord. Sciatica is the next one that a lot of people get, which is compression of the sciatic nerve, which is from the sacral nerve, comes out. This is due to some kind of abnormal heavy lifting or herniated disc or anything can lead to sciatica. Yeah, very pain in the back of the thigh and shooting down to the leg. That's what people get when they get sciatica. Again, bone spur can cause this, herniated disc, spinal stenosis can cause this. Any of these can lead to sciatica right over here. You need, it's very easy. You rule out every other disease and then you say it's only sciatica here. Sometimes a history of herniated discs, or if they have arthritis and they have bone spurs here in the vertebral column, that can lead to that. Ice, application of ice, hot packs, NSAIDs, gentle stretching, very good prognosis. People come out of it, but it takes like maybe a couple months for you to feel better. Spinal muscular atrophy, and that's basically atrophy of the muscles due to sending less messages to the muscle itself. It's a genetic type of disorder. Again, lower motor neurons are affected. It's atrophied. Well, the lower motor neuron causes atrophy of the muscle. So it's genetic. So you're going to have SMN1 or SMN2 genes in your genes to come up with this disease. Okay, so it's spinal muscle atrophy. So you get atrophy of the muscles due to a spinal nerve, nerves, problems. And this is, again, it's genetic. So you have to diagnose it genetically with the SMA, having this SMN1 or SMN2 being there. Gene therapy sometimes can help, but again, the prognosis is not bad unless if it hits the respiratory, and then you have muscle atrophy of the breathing muscles. So this is a genetic muscle atrophy. That's what's happening here. The genes causes the muscles to atrophy. Bell's palsy, that's very common. It could be due to many different diseases, but in general, it could be viral, it could be congenital disorder, it could be genetic disorders. It can be just barely, you can have just Bell's palsy, and that's where you have an inflammation of the facial nerve, which is cranial nerve number 7. So when you inflame the facial nerve, in this case, then you lose the ability to move your muscles here. So this face, the woman is smiling here. She's unable to lift this muscle. So this is the affected part right there. But this could be, it could come along with other diseases, but mainly it has something to do with the inflammation of the facial muscle, facial nerve. So clinical presentation, the patient's unable to smile. You can give them corticosteroids, antiviral, because viruses could cause this. Congenital disorders can cause this. Any type of genetic disorders can cause this. So you have what we call ptosis of the eye. Ptosis is like, like this one here. That's ptosis of the eyelid, drooping of the eyelid. It could lead to permanent nerve damage, so you cannot reverse this in certain situations. Poliomyelitis, basically poliovirus affecting the kids. Way back, we had this type of pandemic that came and hit the USA a long time ago. And also it causes, this virus paralyzes people, weakness and paralysis, destruction of the ventral horn of the motor neuron. So the ventral horn, the ventral horn of the spinal cord is infected by this virus. And that led to, paralysis. So the ventral horn, if you remember, leads to the motor activity. So these kids are unable to move and they become paralyzed because of this. So all what you had to do is you end up having muscle atrophy because you are not sending any motor activity to the muscles. So they become paralyzed. supportive until the virus runs out. Some people, if it's very mild, they came out of it, but many became paralyzed for life, until now. This is a post-polio syndrome type. So that's actually after you get infected, few years after, you can get these symptoms again, which is a little paralysis that you get paralyzed, but you come out of it. Just an attack, kind of polio attack, they call that. All right, Guillain-Barré syndrome. This is an autoimmune disorder. It has something to do with the myelin sheaths, okay? So Guillain-Barré, the destruction of the myelin sheaths, all right, in the peripheral nerves. It's autoimmune. Slowly you destroy the myelin sheaths, and then usually it starts from legs up. Okay. Now don't confuse this with the amyotrophic lateral sclerosis, which could be anywhere in the upper arms and lower legs, both upper and lower motor neurons. But in this guy, in this one, usually it starts from the leg up. So you get paralysis down here, and then it keeps, so the first symptom is you're unable to stand and walk and all that. You end up going on a wheelchair, and then eventually the destruction of the myelin sheaths keeps going up, and then eventually it hits the arms and maybe the breathing muscles, and then you have an issue here. So Guillain-Barré is basically the myelin sheaths being destroyed. So signs and symptoms, arrhythmias, paresthesia, and all that. And that's how you go ahead and diagnose it. Treatment, no real treatment. People die because of that. All right, we're done. So this is the nervous system. Let me just stop recording.